Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. In this week's video, we're in session B of our 5th session in this new program, which is entitled the QME's Clinical Rounds. And in session 5, we began a 2-part series dealing with ulnar-sided wrist pain. Ulnar-sided wrist pain. And today we're in session 2 of this 2-part series. So before we continue with the topics of today's discussion, I want to ask you, have you ever experienced ulnar-sided wrist pain? Are you familiar with the pain and the clicking and the clunking and the grating sounds that can accompany ulnar-sided wrist pain? I know I've had much experience with ulnar-sided wrist pain, and so when examinees come to the face-to-face evaluation with me and they tell me about all of these symptoms with their wrist, I can relate to those symptoms. Because as a chiropractor myself, many of the maneuvers that we utilize as chiropractors involve awkward positioning of the wrist in forcible extension and pronation and sharp and maximal ulnar deviation, and there's all these maneuvers that we as chiropractors do that put repetitive stress onto the wrist and particularly onto the sensitive and delicate structures on the ulnar side of the wrist. Or if you're not a chiropractor, perhaps as one of your hobbies you like to lift weights, and because of the positioning of the maneuvers required in weightlifting, you're also in some of these compromised wrist positions that also involve loading of the wrist when the wrist is loaded with barbells and dumbbells and forced hyperextension while doing push-ups. That could be a cause of ulnar-sided wrist pain that you may be familiar with. Or maybe you like to ride motorcycles, and as a motorcyclist you find yourself leaning forward down to reach the handlebars of your motorcycle with your wrists in extension and ulnar deviation as you operate all of these hand controls in being able to navigate and pilot a motorcycle. So many activities of daily living that we engage in can be a source of pain on the ulnar side of the wrist. And in this discussion, we began with 4 major topic headings. And in our last session, we made it all the way through the discussions of anatomy, where we talked about all of the structures that tend to become aggravated and provoked with repetitive and cumulative trauma to the wrist. We made it through pathoanatomy, and here we're limiting our discussion to 2 major findings in the wrist. We're talking about those injuries that involve an acute injury, which causes a carpal ligament tear, whether that be an interosseous ligament or a ligament that spans both the radiocarpal joint and or spans the intercarpal joint. And we got into, so we're limiting our discussion to acute injuries, which would be the ligament tears, and the chronic injuries that have to do with activation, aggravation, and rendering symptomatic a pre-existing condition of the wrist, which is an imbalance in the lengths of the radius relative to the ulnar bone, known as ulnar variance. And in our last session, we began our discussion of ulnar variance by looking at some x-rays and making some measurements for the assessment of ulnar variance. So that brings us to today's session, where we're going to talk a little bit more about some of the diagnosable conditions that you will encounter in your career as a qualified medical evaluator. With regards to the acute injuries to the wrist, we're going to talk about examinees who come to us 6 months, 9 months, a year later with late effect of the acute wrist sprain injury to the ulnar aspect of the wrist. These are people that are going to come to us and complain of weakness, of loss of range of motion, of pain, on pronation, supination, radial and ulnar deviation. So there'll be suffering the late effect of an acute wrist sprain. And then we have the more chronic conditions that we're going to be diagnosing as qualified medical evaluators. And both of these conditions are related to changes in the ulnar variance. So with ulnar abutment syndrome, we're going to see examinees with ulnar abutment and or ulnar impaction syndrome in cases of a positive ulnar variance where the length of the ulna bone is slightly longer than the length of the radius bone. That's going to cause impaction and abutment of the ulna onto the carpal bones on the ulnar side of the wrist, such as the lunate and the triquetrum, and it's going to cause stress to the triangular fibrocartilage and the connective tissues within that space that's ordinarily occupied when the ulna is slightly shorter than the radius bone. So that's ulnar abutment syndrome. And then we're going to talk about ulnar impingement syndrome, and this here says impaction syndrome, but it should say ulnar impingement syndrome. And we see ulnar impingement syndrome due to chronic aggravation of a negative ulnar variance wrist. Negative ulnar variance wrist is when the ulna bone, here represented by this finger, is relatively shorter, significantly shorter than the radius bone, in which case there develops a painful pseudo-articulation here down below the typical articulation where the ulna articulates with the sigmoid notch of the radius bone. So there develops a painful pseudoarthrosis which can become inflamed, can become degenerative, just like any other synovial joint, can become degenerative and arthritic with time and cause the examinee pain, weakness, and loss of strength due to pain in the ulnar side of the wrist. So we're going to go over a little bit more about those particular conditions. And then finally, when all is said and done, we're going to talk about some of the permanent impairment rating options that you have available for examinees who present to you with ulnar-sided wrist pain. Okay? So let's jump right into the meat of today's discussion, and let's talk about diagnosable conditions for those examinees who present with ulnar-sided wrist pain. Okay, so let's talk about those diagnosable conditions that you're going to see in your career as a qualified medical evaluator. Now, we're going to be seeing three basic variations on the theme of ulnar-sided wrist pain. And as I said, those examinees that we're going to see are going to be those that have either had an acute injury at one point in their career as an injured worker, or they're going to be presenting to you with a cumulative trauma injury to the wrist, in which case they've developed chronic wrist pain over a period of time. So those are our two basic scenarios. We have examinees who will have acute pain and those that will have chronic pain, okay, or who will have suffered an acute injury or will have suffered a cumulative trauma injury. Now, in those cases of cumulative trauma injury, we're going to be dealing with the radiographic finding of ulnar variance. And remember that a normal wrist has what is defined and what is described as neutral ulnar variance. With neutral ulnar variance, the radius bone and the ulna bone, this is the distal radius and the distal ulna, down at the distal radial ulnar joint and at the radiocarpal and ulnocarpal joints. Okay, the radius and the ulna, the articular transition from the articular surface of the radius to the articular surface of the ulna is a relatively level transition, is a flat transition, is a continuous transition from the lunate fossa of the radius to the articular head of the ulna bone. So those bones are relatively evenly aligned, and the transition between articular surfaces is continuous and uninterrupted and flat. We call that a neutral ulnar variance. Now, when the length of the ulna bone starts to creep up and starts to elongate greater than the length of the radius bone, those articular surfaces are no longer continuous. Can you see the step deformity created by the differential lengths of the radius bone here and the ulna bone here? Can you see that that creates a step defect at the articular transition? This is a source of chronic wrist pain due to the development of what's called ulnar abutment or ulnar impaction syndrome, where this elongated ulna bone here impacts upon the ulnocarpal articulation and compresses both the connective tissues between the distal aspect of the ulna bone and the proximal row of carpal bones with which the ulna articulates. So this creates a continuous impaction and compression of the tissues on the ulnar aspect of the wrist, and this will over time create degenerative changes in the carpal bones in the wrist that receive the ulna in the formation of the articulations between the ulna and the lunate bone and between the ulna and the triquetrum bone. The lunate and the triquetrum will start to show degenerative changes. And that's something that you can pick up on radiographs, and that's a radiographic finding for ulnar abutment or ulnar impaction syndrome. Now, on the other hand, when the ulna bone is significantly shorter than the radius bone, can you see again that there's a step defect between the articular surfaces of the distal radius and the articular surface of the distal ulna, and this creates a greater gap between the ulna and the proximal row of carpals, in contrast to ulnar abutment syndrome, where there's a diminished space between the end of the ulna and the carpal bones. Well, the ulnar impingement syndrome creates a new phenomenon where that shortened ulna bone creates a pseudo-articulation down on the shaft of the radius bone where there is no articulation. The articulation is typically at the distal aspect of the radius bone where the sigmoid notch on the radius bone receives the articulation with the ulna bone. Well, with ulnar impingement syndrome, there's the creation of a painful pseudoarthrosis down the shaft of the radius bone, and this can become inflamed and degenerative and cause examinee symptoms over a period of time. So we're going to talk about some permanent impairment rating options for this type of a finding. And then for examinees who have suffered an acute injury, an acute ligament sprain, and who present to the qualified medical evaluation with the late effect of a wrist sprain injury, we're going to talk about some permanent impairment ratings for the typical findings that we're going to encounter in those examinees who've suffered a wrist sprain. Now, typically we're going to see sprain of the following main wrist ligaments. We're going to be dealing with injuries to the scapholunate ligament. And the scapholunate ligament is an interosseous ligament between the scaphoid bone and the lunate bone, holding the scaphoid and the lunate together. And when there's a disruption of the scapholunate ligament, these two bones can become dissociated from each other. Dissociated, in other words, they're no longer tightly associated by virtue of an intact ligament. They become dissociated, and this is referred to as carpal instability dissociative. And the AMA guides provide for a permanent impairment rating for this and other types of dissociative carpal instabilities. The other type of dissociative carpal instability described in the AMA guides deals with injury to the next more medial interosseous ligament, which is the lunotriquetral ligament. So you'll notice that the lunate bone is central to injury to both of these ligaments. With the injury to the scapholunate ligament, the lunate bone becomes dissociated from the scaphoid. With injury to the lunotriquetral ligament, the lunate then becomes dissociated from the neighboring triquetral bone. So this is another form of dissociative carpal instability, also referred to as CID, carpal instability dissociative. And then in addition, we're going to see injuries to the radioscapholunate ligament and other ligaments that span the radial carpal joint, the ulnocarpal joint, and even span the articulation between the proximal row of carpal bones across to the distal row of carpal bones, or ligaments that span the entire distance from the radiocarpal joint across the proximal row of carpal bones and into the distal row of carpal bones, and similarly from the ulna bone to across to attach on the distal row of carpal bones. So these extrinsic ligaments, when those are sprained, they create a form of carpal instability referred to as non-dissociative. Carpal instability, non-dissociative. And the AMA guides provide 4 permanent impairment ratings for examinees who have suffered injury to these types of ligaments, which are not the interosseous ligaments, but that are extrinsic ligaments to the wrist that cross the articulations between the proximal to distal carpal row and even across the articulation between the distal radius and the proximal carpal row. Okay? Now, the problem with these type of wrist injuries is that these types of wrist injuries have a tendency to become chronic and become refractory to treatment. And I've highlighted here for us in yellow the ulnar abutment or ulnar impaction syndrome, because we do have some statistics regarding treatment outcomes for examinees who have presented with this type of a condition. Now, typically for the treatment of these conditions, treatment is generally conservative, involving non-steroidal anti-inflammatory medications, physical therapy, bracing, activity modifications, and other conservative measures that attempt to calm down the inflammation at the distal radial ulnar joint and at the ulnocarpal articulations. Now, specifically in the case of ulnar abutment or ulnar impaction syndrome, there is a surgical correction that examinees in the workers' compensation system can undergo in those cases that involve a refractory wrist, a wrist that does not respond to conservative treatment measures. So for ulnar abutment syndrome, the surgical correction is what's referred to as an ulnar osteotomy. So imagine this. With ulnar abutment syndrome, we have an ulna bone here, which is relatively longer than the radius bone here. And that creates a compression and an impaction on the distal ulna as the ulna articulates with the proximal row of carpal bones, specifically the lunate and the triquetrum. So there's chronic compression and impaction there. Well, in order to relieve the chronic compression and impaction there, an ulnar osteotomy reduces the length of the ulna bone by removing a piece of bone out of the shaft of the ulna bone. In other words, the articular surface of the ulna bone is left unperturbed. The articular surface, the articular end of the ulna bone, is not disturbed, is not the operative site. The operative site is along the shaft of the ulna, where a section of the bone is removed sufficient to allow proper alignment of the ulna now with the radius bone. And then after that section of bone is removed, there's a period wherein the operative ends of the bone are braced with a metal piece of hardware, which can then be removed once the bone has healed and the separation between those operative ends has healed and become a solid fusion. Okay? But unfortunately, in the workers' compensation system, examinees who undergo treatment for ulnar-sided wrist pain, and specifically for ulnar abutment syndrome, generally have poor response to these treatment interventions, and therefore they're going to present to you in the qualified medical evaluation with a report of ongoing symptoms and activity limitations. And let's take a look at a recent study which describes the outcomes of workers' compensation patients who undergo treatment for ulnar-sided wrist pain. Okay, so here we have a study published in 2007 in the journal Clinical Orthopedics and Related Research. And this is a study entitled Factors Which Affect the Results of Ulnar Osteotomy for Ulnar Impaction Syndrome. So what they wanted to determine is they wanted to determine what are some of the variables that seem to influence the outcome of surgical treatment for ulnar impaction syndrome. And they tried, the purpose of this study is to help medical orthopedists and hand specialists to identify those candidates for surgical correction of ulnar-sided wrist pain that would be expected to respond favorably and positively to the ulnar shortening procedure. So they wanted to explore the factors, some of the factors that affect the results for this particular procedure. And what they found here, and we'll just read from the abstract here on the left, they found that a long duration of symptoms and workers' compensation predicted worse clinical scores. So the authors suggest that they recommend considering these two factors when deciding whether to perform this procedure. So if we scroll down through this study, they have a table here, table number 1, which lists some of the variables that they used in considering what are the factors that affect a positive or a negative outcome for examinees who undergo a surgical ulnar osteotomy. So they assessed whether patient age could be a factor. They assessed whether the dominant versus the non-dominant side could be a factor, whether the examinee was involved with workers' compensation could predict the outcome, the pain, the symptom duration, the preoperative range of motion of the wrist, the preoperative grip strength, the preoperative clinical score, which is an assessment of the examinee's overall wrist pain condition. What about the amount of shortening that the ulna underwent? Did examinees who underwent a small shortening fare more positively and fare better in terms of their outcome than examinees who had a large amount of ulnar shortening removed from the ulnar bone? So they considered all of these factors, and they wanted to determine which factors predict a positive outcome and which factors predict a negative outcome for this ulnar shortening procedure. And if we go straight to the conclusion, here's one of the conclusions here, is that patients receiving workers' compensation had the likelihood of lower clinical scores. And then if we come down to the discussion, they tell us that patients with a long persistence of symptoms may be attributable to the severity of clinical symptoms and to pathologic changes in the wrist. Our data indicate patients receiving workers' compensation with more than 6 months duration of symptoms may not respond favorably to this procedure. So, consistent with other studies that we've talked about in other programs, examinees in the workers' compensation system tend to respond more poorly, or tend to respond poorer, than patients outside of the workers' compensation system for the same surgical correction, for the same diagnosable condition. So we can expect this in our examinees who present to us in the face-to-face evaluation. We can expect them to complain that they have not responded positively to the treatment that they've received. We can expect them to report ongoing symptoms and ongoing limitations with activities of daily living, even in the context of protracted disability, perhaps in the form of total temporary disability, and also in the context of extensive and perhaps even exhaustive and perhaps even surgical treatment for their ulnar-sided wrist pain. These particular examinees in the workers' compensation system just seem to respond, for whatever reason, they tend to respond poorly to treatment interventions. So if that's the case, and if we have examinees who fail to return to pre-injury condition, what are some of the permanent impairment options that we have available to us for rating the loss of function of the wrist in these particular examinees? Let's talk about some of those now. Okay, so when it comes to providing for a permanent impairment rating for these examinees who have suffered ulnar-sided wrist injury, whether it be an acute injury due to a ligament sprain or a chronic injury due to either positive or negative ulnar variants leading to either ulnar abutment syndrome or ulnar impingement syndrome, we have several options available to us for accurately rating these examinees. So your basic impairment rating findings are going to include, number one, abnormal motion, where the examinee has lost one or more of the entirety of the range of motion in either flexion, extension, radial deviation, ulnar deviation, and then also pronation and or supination. So with many of these ulnar-sided wrist pain conditions, it's the ulnar deviation and the pronation that are going to be the ranges of motion that are both limited, and the ranges of motion wherein the examinee is also going to be weak, because that's the particular aspect of the range of motion, or the particular portion of the range of motion wherein the pain is elicited as the ulnar sided tissues of the wrist begin to complain and begin to become stretched or compressed or stretched. Okay, so we have abnormal motion as one of our rating options. We also have decreased strength of the wrist, and we're going to talk about that a little bit more as we go. We also can assess the examinee for loss of grip strength when the function of the wrist is affected. It's going to affect the examinee's grip strength, so this may be one of the impairment rating methods you may want to employ. And then finally, for those examinees for whom we order the radiographic studies to assess for this finding, there may be instability of the proximal row of carpal bones that can be detected on radiographic studies, in which case we could provide for a permanent impairment rating due to the dissociative forms of carpal instability, which would present on radiographic measurements. And then also the AMA guides also provide for an impairment rating for the non-dissociative type of carpal instability. And so we'll talk a little bit more at length about these two permanent impairment rating options, the decreased strength of the wrist and then also the carpal instability. Now, when it comes to rating impairments of the upper extremities due to loss of strength, Table 1635 of the AMA guides provides impairment values for losses of strength of both the shoulder and the elbow joint. But Table 1635 does not mention how to rate examinees who suffered a loss of strength of the wrist. But they do provide for the shoulder and they do provide for the elbow, so we can analogize to this particular table in providing for an impairment rating for our examinees who suffered loss of strength of the wrist. So if you'll follow along with this carefully, you'll understand the philosophy of how these permanent impairment ratings can be arrived at for the wrist. So Table 1635 tells us that the shoulder functional unit represents 60% of upper extremity function, whereas the elbow represents 70% of upper extremity function. Well, just to create an analogy with the wrist, if we analogize to 60% for the shoulder and 70% for the elbow, the guides tell us in section 16.4H that the elbow represents 70% of upper extremity function, and indeed that is carried over to Table 1635. Well, in section 16.4G, just the immediately preceding section, they tell us that the wrist functional unit represents 60% of the upper extremity function, similar to the shoulder, which represents 60% of upper extremity function as well. So we can analogize to the shoulder at 60% for examinees who have suffered a loss of wrist strength, similar to examinees who have suffered a loss of shoulder strength. And we can use table 1635 to obtain our impairment rating values here. Well, 16.4G goes on to tell us that the wrist has 2 units of motion, each contributing a relative value to its function. The units of motion are going to include flexion and extension. Flexion and extension, similar to the shoulder here, has flexion and extension. And then there's also radial and ulnar deviation, which can be referred to as adduction for ulnar deviation and abduction for radial deviation. So we can analogize to the wrist to the shoulder to provide loss of strength impairment values for those examinees who are involved at the wrist but who may not be involved at the shoulder. And we can use table 1635 to come up with our impairment rating values here out of this column. So in providing your permanent impairment ratings for the wrist, you're going to analogize to table 1635, analogizing that the wrist is an unlisted condition in table 1635. It's not a listed condition in this table. The listed conditions in this table involve the shoulder and the elbow, but we can analogize the unlisted condition of the wrist to the listed condition of the shoulder, specifically the shoulder, because both the shoulder and the wrist represent 60% of the upper extremity function. So according to 16.4G, the wrist has 2 units of motion, flexion and extension, which account for 70% of wrist function, and then radial and ulnar deviation, which comprise 30% of wrist function. So notice that radial and ulnar deviation totals 30% of wrist function. That is roughly the same. This represents 18% of upper extremity function, same as ab and adduction of the shoulder, exactly the same. So the analogy from 16.4G across to 16.35, at least regarding ulnar and radial deviation, is an exact analogy, and you can use these numbers exactly from the table as they are described. Now, for flexion and extension accounts for 42% of the wrist function, upper extremity function, slightly more than the combined effect of flexion and extension at the shoulder. So you're going to have to be a little bit creative in providing for your permanent impairment ratings out of this range, out of this possible range of numbers here that are provided for in table 1635. So in your report, you would simply write that up, something similar to the following. You would say, Mr. Jones has 4 out of 5 left wrist strength in resisted flexion. I estimate strength deficit to be 25%. By analogy to table 1635 and considering that the functional unit of the wrist is 60% upper extremity impairment, and that's described on the AMA guides, page 466, and that wrist flexion makes up 35% of the function of the wrist. 35 is half of 70. Okay, so section 16.4G tells us that wrist flexion and extension makes up 70% of wrist function. So considering only flexion, we divide that in half. And then we provide for our permanent impairment rating right out of table 1635 by analogy to the shoulder. So this qualifies for 6% upper extremity impairment, or your number may vary based upon your percentage of estimate of strength loss of the wrist. For wrist extension, Mr. Jones has 4/5 wrist strength and resisted extension. Estimate strength loss to be 25%, considering that the wrist makes up 60% of the upper extremity, and that wrist extension makes up 35% of the function of the wrist. This qualifies for 6% upper extremity impairment by analogy to table 1635. So simply repeat that procedure for both pronation and supination if you find losses of strength in those particular ranges of motion, and then total up all of your impairments by adding the impairments for the flexion percentage impairment, the extension percentage impairment, the pronation percentage impairment, the supination percentage impairment, and then come up with your total upper extremity impairment. If that's the end of it, if you're done with it, you would then convert that into a whole person impairment through the use of table 16-3 to provide your final whole person impairment rating. So those are some permanent impairment rating ideas for examinees who have suffered a loss of strength of the wrist. Let's talk now about the permanent impairment ratings due to either physical examination findings or radiographic findings of carpal instability. And then for those examinees who suffered some form of carpal instability, either as a result of an acute ligament injury that happened as a one-time occurrence, or as a result of the chronic and repetitive and cumulative trauma associated with either ulnar impaction syndrome or ulnar impingement syndrome due to positive or negative ulnar variance at the wrist, the AMA guides provide for carpal instability permanent impairment ratings when that carpal instability pattern can be detected on radiographic studies. So thus the importance of ordering the necessary radiographic studies for your particular examinee in each and every wrist pain case, So a couple of good reasons to order a 6-view series of wrist x-rays in each and every wrist pain case. Number one, to determine the presence or the absence of any ulnar variance to begin with, and that will lead you greatly down your diagnostic and medical decision-making pathway when you find an examinee who truly has a bona fide finding for either positive or negative ulnar variance. So that's one thing in the beginning. Number two is to assess for these carpal instability patterns that are described in the AMA guides, and you cannot do this in the absence of the specific radiographic views that are used for the identification of each one of these particular carpal instability patterns. So for the dissociative carpal instability patterns, we do an assessment on the radiolunate angle. The radiolunate angle should be 0 to 10 degrees in either the positive or the negative direction. So as that lunate moves from 0 to 10 degrees in the positive direction to 0 to 10 degrees in the negative direction, there's a range there of 20 degrees of lunate motion. Well, when the lunate becomes dissociated from either the scaphoid or from the triquetrum and the lunate becomes unstable, the lunate will show greater than 10 degrees of motion in either the positive or the negative direction. And that's a measurement that you can obtain, and this is a finding that you can readily observe when you order the necessary radiographic studies. For the scapholunate angle, again, similarly, the scaphoid bone and the lunate bone have a normal angular proper positional relationship to each other in the normal wrist. And when there is a dissociation and some damage and injury to the interosseous scapholunate ligament between those two bones, and those two bones become dissociated rather than associated, they become dissociated, then the angles change between the posture of these two bones in the neutral wrist, and that's a finding that can only be determined when you take and order the necessary radiographic studies. So when you make these measurements, you'll find that the normal angle of the scapholunate angle is somewhere between 45 and 60 degrees. As the scaphoid and the lunate become increasingly dissociated from each other, that angle will increase and provide for an increasing permanent impairment rating that the examinee would never qualify for in the absence of the particular X-ray images upon which this angle is measured. And these two angles, the radiolunate angle and the scapholunate angle, those are measured on the lateral closed fist stressed view X-ray. Okay? Similarly, the scapholunate gap is a measurement of dissociative carpal instability between the scaphoid and the lunate bone. The triquetrolunate step-off is a measurement that assesses the association of the triquetrum bone with the lunate bone. And remember, on the ulnar aspect of the wrist, the distal ulna articulates with a piece of the lunate bone and the majority of the triquetrum bone. And so we have the ulnocarpal articulations there between the ulna and the lunate and the ulna and the triquetrum. And then also there's the interosseous articulation there between the lunate and the triquetrum in the proximal row of carpal bones. So that whole area can go sour and become degenerative and suffer carpal instability patterns, and one of those is measured through the assessment of the triquetrolunate step-off. And then finally we have the X-ray finding of ulnar translation, which describes the positioning of the lunate bone relative to the radius bone. And so the lunate bone, as you know, sits in the radius bone in the lunate fossa. And in the normal wrist, more than 50% of the body of the lunate bone rests on the radial side of the radius, sits within the lunate fossa within the radial side of the radius. But in degenerative conditions, including rheumatoid arthritis or trauma to the wrist, the lunate bone can translate ulnarly and can come off of its supportive base in the lunate fossa of the radius bone. So this lunate bone here can translate ulnarly such that greater than 50% of the lunate bone is ulnarwards, whereas in the normal finding, greater than 50% of the ulna should be radialwards. Okay, so here's the 50%, with 50% of the lunate on the radius and 50% over the ulna. In ulnar translation, more than 50% of the lunate is off of its articulation with the radius bone. So that's a finding for ulnar translation. So doctors, isn't that fascinating? Ulnar-sided wrist pain is a common problem that you're going to encounter in the industrial setting, and so it pays to be familiar with these various impairment rating options that are available to you, including those for the assessment of the various forms of carpal instabilities. So doctors, I hope this helps you. The purpose of this program is to provide for you a brief clinical review of some of the common conditions that you're going to encounter in your career as a qualified medical evaluator. And just as the briefest summary of this program, in session 1 we talked about carpal tunnel syndrome, which you're going to see all the time. So I encourage you to review some of the information that we discussed regarding the flick sign and how the flick sign is such a strong indicator of either the presence or the absence of bona fide carpal tunnel syndrome. We talked about a couple of spinal conditions such as Schmorl's nodes and cervical ribs, and how those conditions, those pre-existing conditions, in the case of cervical ribs certainly, and sometimes in the case of Schmorl's nodes, or Schmorl's nodes can actually be caused by the industrial injury, but in most cases they will represent pre-existing conditions. How these pre-existing conditions contribute to the permanent impairment suffered by the examinee, and we talked about how to accurately rate these conditions for permanent impairment. We talked about rotator cuff tendinopathy, and you're going to see those cases all the time. And certainly the AMA guides provide for generous permanent impairment ratings and generous and creative permanent impairment ratings for examinees who suffer from rotator cuff tendinopathy, because tendinopathy, once it begins its development, the progressive degeneration of a tendon, which is referred to as tendinopathy, once that degenerative process continues, the tendon has a very low likelihood of ever recovering to a pre-injury condition. And this just has to do with the degenerative nature of tendons, and also due to the poor treatment that's provided in the workers' compensation system for this particular condition. It seems that the treatment for this condition, at least in workers' compensation, has not yet caught up to the treatment that's offered for the same condition outside of the workers' compensation system. And then finally today, we talked about ulnar-sided wrist pain, which you're going to see all the time in those examinees that are involved in repetitious activities at the workplace. Repetitious upper extremity activities seems to wreak havoc on the delicate structures on the ulnar side of the wrist, especially considering that ulnar variance tends to progress toward a positive ulnar variance with aging. It seems that positivity of the ulnar variance is the normal degenerative condition of the wrist related to aging and wear and tear on the wrist. So this is going to lead to an ever-increasing population of examinees presenting to you with ulnar abutment and ulnar impaction syndrome on the ulnar aspect of the wrist. And so we talked about some impairment rating options for you. So doctors, I hope this helps you. I want to thank you for your commitment to excellence and your persistence in continuing with this program all the way to its terminus here. So this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on today's discussion. Look forward to being with you on future discussions as well. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.